AdventHealth Cancer Institute in Orlando, Florida is recognized for the exceptional care it provides to patients with non-small cell lung cancer. In this video series, oncology specialists from the lung cancer multidisciplinary team share their perspectives. This video focuses on best practices in Stage III non-small cell lung cancer. In this episode, we asked oncology specialists from AdventHealth several questions. You may go to a specific question by advancing to the associated timestamp. What are your treatment goals for your patients with Stage III disease? And how do you help make sure they get appropriate treatment at AdventHealth?
We approach Stage III lung cancer patients with a curative intent.
In my experience, it's very important at the outset to make sure that the diagnosis and staging is correct at the very beginning of treatment. If you're going to offer standard of care for Stage III disease, it follows that you want to be absolutely sure that you're dealing with Stage III disease and that it's not an earlier stage masquerading as more advanced stage or a more advanced stage masquerading as an earlier stage. At AdventHealth, we are fortunate in that we have access to certain techniques that will make the diagnosis and staging easier.
For the pathologist, probably the most important is to make sure the staging is correct. So we thoroughly examine all the lymph nodes that come with the specimen to make sure we provide accurate stage for the clinician for them to formulate the appropriate treatment.
Can you talk about some challenges you have experienced with radiation therapy in Stage III disease?
Every patient's anatomy is different and unique to that patient. The art of radiation therapy is to target the tumor and try to minimize the amount of radiation that the normal organs in the chest, like the spinal cord, the esophagus, the heart, and the lungs, are getting acceptable doses of radiation.
Because our therapy is a local treatment that targets the visible tumor, the two main issues really are location and volume. If you have a small volume, it can be easily treatable unless it is located next to an important critical structure that it would be unsafe to give a high dose of radiation to. And then conversely, patients who present with large volume disease can run into challenges related to giving high doses of radiation to multiple organs or multiple sensitive areas. Despite our improvements in the ability to target and deliver the radiation, concerns about the damage that radiation can cause in the short term and the long term have had an impact on our treatment approach and will sometimes sort of form a boundary as far as what we feel we can safely do within a particular case presentation.
What are some of the factors you keep in mind when determining if a patient should get concurrent CRT?
In my experience, poor performance status, unfavorable tumor location, or large tumor volume will force a modification of our radiation treatment regimen. My guiding principle is that you don't want your treatment to cause more problems than the disease itself.
When treating your Stage III NSCLC patients, what's next following concurrent chemoradiation treatment?
We know that the standard of care is concurrent chemoradiotherapy. We also know that the next step is to consider consolidation immunotherapy after completion of chemoradiotherapy in those patients that do not have disease progression. In my experience, most patients with Stage III disease and a good performance status will be eligible for consolidation immunotherapy. Advances in immunotherapy have made us kind of rethink how we treat Stage III patients. And so the importance of getting patients through the chemotherapeutic regimen with minimal toxicity and getting them through on time to allow them to move on to consolidation immunotherapy. So I do everything I can doing concurrent chemoradiotherapy to mitigate toxicity and allow the patient to be in great shape to start immunotherapy as soon as possible after completion of chemoradiotherapy.
My goal is to get the patient to the stage where we give consolidation immunotherapy and the treatment of Stage III non-small cell lung cancer.
How do you determine when to start immunotherapy after concurrent CRT at AdventHealth?
Our medical oncologists see these patients regularly, so they are plugged in and they will know when the patients are coming towards a finish of radiation. In our practice, we try to get the treatment started within 28 days of finishing radiotherapy. The medical oncologist will typically schedule these patients for clinical follow-up around that time to make an assessment of whether they're suitable to get started within the shorter time frame or whether they need some additional time to recover.
In my experience, I tailor my assessment, which is essentially by repeating the chest and abdominal CT scan based on how the patient does. If the patient kind of sails through chemoradiotherapy, has very little esophagitis, has very little fatigue, and has really done quite well, then I will do a CT scan within a week or so of completion of chemoradiotherapy. If it doesn't show any disease progression, I'll get the immunotherapy started relatively quickly. If the patient has had more significant esophagitis or perhaps a greater level of fatigue, or maybe some other toxicity in your sense is that you need to give them a little time to recover from that toxicity before moving on to immunotherapy, then I'll typically scan that patient at about 4 weeks or so. That's kind of the general strategy I use in this population.
In your opinion, what can lead to early treatment discontinuation?
One of the things that will sometimes come up is you can very easily confuse post-treatment changes and inflammation for cancer progression.
Living with Stage III non-small cell lung cancer isn't easy. How do you prepare your patients for the road ahead?
We tell patients about the treatment plan at the beginning so they're prepared and have no surprises. A nurse educator will meet with the patient in person, by phone, or by a video conference to go over all their treatments and what to expect. The individual physician offices also give patients some education when they're telling them about their therapy, so our nurse educator builds on that.
Can you share some practical advice about treating patients with Stage III non-small cell lung cancer?
So again, I think decisions in the Stage III setting should be made by the team. There are a growing number of treatment options for these patients, but we do know that in the chemoradiotherapy world that there are certain platforms of certain chemotherapy drugs as well as certain radiation strategies that have been time-tested in phase 3 trials.
I believe that it is critically important in the community for a patient that has what you believe to be Stage III disease gets seen by all 3 of the care disciplines, so a thoracic surgeon, medical oncologist, and a radiation oncologist. Within all of those disciplines, there are treatment types and techniques that the other disciplines may not be fully aware of that can improve outcomes.
Basically, I advise my colleagues that these cases should be discussed in a multidisciplinary fashion with the relevant disciplines, particularly radiation oncology and medical oncology. Put a treatment plan, be all involved at the timelines. When is radiation starting? When is chemotherapy starting? When are we gonna stage the patient? And make everybody that's part of the treatment decisions.
We hope you found these multidisciplinary insights and best practices helpful. Look for other episodes from TOPS that highlight practical perspectives in managing non-small cell lung cancer.